you so much. All right, and want to give a big thank you to the medical writing team who helped put these slides together. So we can move on to the next slide. So today we're going to talk about the risks of alcohol use disorder and high-risk drinking, some culturally safe approaches that we can apply when talking to patients about their substance use, and also discuss comorbidities and complications of heavy alcohol use in primary care. So moving on to the next slide. The majority of Canadians age 15 and older drink in excess of our new lower risk drinking guideline recommendations, which are 2 or fewer standard drinks per week. And about 20% of Canadians in that same age group will be diagnosed with an alcohol use disorder in their lifetime. Alcohol contributes significantly to morbidity. So over 10,000 alcohol-related deaths occur in Canada annually, and the rate of hospitalizations attributed to alcohol are also quite significant. So really addressing this in primary care and seizing those opportunities to engage patients in discussions around how alcohol fits into their life can help with their life expectancy and quality of life. Next slide. When we look at risks associated with alcohol use, we see risks with single-time alcohol use as well as more chronic exposure. So with short-term alcohol exposure, there are things like injuries, violence, motor vehicle accidents that alcohol can be implicated in. And longer-term exposure, we see harms occurring in the form of cancer, heart disease, liver disease, issues with the GI tract like gastritis, and also development of alcohol use disorder. Next slide. So in Canada, we define a standard drink of alcohol as 13 grams of pure alcohol, the volume of which depends on what beverage you're drinking. And new lower risk drinking guidelines really shifted the focus on how we talk about alcohol to emphasize that essentially less is more. So newer evidence has suggested that having more than 2 standard drinks per week increases your risk of longer-term health consequences like things like cancer. If we increase that to 7 drinks a week, which is 1 standard drink a day, that puts you at high risk of developing things like cardiovascular diseases attributable to your alcohol use. So we've really shifted the way that we talk about alcohol use to focus more on moderation and lower levels of drinking than were previously thought to be safe in older versions of those guidelines. Next slide. So when we look at risk of death and disability attributed to alcohol, as we increase alcohol consumption in the week, when we go from 2 drinks a week, that's about 1 in 1,000 risk of premature death. And when we increase that to 6 drinks a week, that's about a 10-fold increase in your risk of premature death. Next slide. So we've talked about why it's important to address alcohol use, but really primary care is the ideal environment to do this engagement because we already have a trusting relationship with patients, and we can also opportunistically add this sort of preventative guidance in when people come in for non-alcohol related clinical questions, or not immediately alcohol related anyway. Next slide. So we can talk about alcohol use in primary care and client intakes when you're doing just general assessments, annual preventative screenings, and also in any visit, particularly ones where we see an alcohol-related comorbidity. So someone coming in with anxiety, depression, or hepatic disease, or gastritis, these are really good opportunities to talk about alcohol use. In addition to just any visit at all, we were talking about health. In this next portion of the talk, we'll talk about Indigenous cultural safety. And I'll start by humbly acknowledging that I'm not an Indigenous person and I'm not an expert in this area, but providing culturally safe care is something that I strive for and something that requires ongoing self-reflection, effort, and improvement from everyone in the healthcare system, myself included. And in this vein, it's important that we talk about the impact of colonialism when discussing substance use with Indigenous people. This part of the presentation can evoke some complex emotions, so feel free to take some time if you need during this portion of the talk. So we'll start with some definitions. So cultural safety is the outcome of respectful engagement in a in a clinical encounter. It recognizes and strives to address power imbalances embedded in the health system. And it results in an environment that's free of racism and discrimination, or people feel safe receiving care. Moving on to cultural humility, this is a lifelong process of self-reflection and self-critique with a commitment to learning alongside others. In doing this, we need to humbly acknowledge ourselves as learners and understanding our personal and systemic biases that take place. So building cultural humility builds mutual trust and respect and results in cultural safety. All right, next slide. When we take a step back in history to look at alcohol use in Indigenous people and how this has affected how Indigenous people today, it's important to look at sort of the history of alcohol use over time. So settlers initially introduced alcohol to Indigenous people. And then over time in the Indian Act, alcohol was used as a tool for discrimination and criminalizing Indigenous people. The Indian Act made it so that Indigenous people were prohibited from purchasing and consuming alcohol and also entering establishments where alcohol was served. And this is significant because this is where a lot of social interactions took place. So it really served as a way of othering and discriminating against Indigenous people. The Indian Act also included that if people were to give up their Indigenous way of life, then they could and prove abstinence, and they could gain entry into these places. So it served not only as a tool to criminalize and malign Indigenous people, but also as a tool for assimilation. So lots of history there in terms of how alcohol has harmed Indigenous people through colonial structures over time, and we still feel the reverberations of that today. So there can often be stereotypes around Indigenous people and alcohol use, but it's really important to acknowledge that when we look at the actual statistics, Indigenous people in Canada are more likely to completely abstain from alcohol use than non-Indigenous Canadians. So this really is a stereotype. It's obviously very important to take into account past and ongoing colonialism and how that trauma, intergenerational trauma, can impact someone's substance use. Things like residential schools in the 60s scoop, but acknowledging that there are many Indigenous people that don't consume alcohol and have healthy relationships with alcohol as well. So not bringing that bias into the encounter. All right, next slide. So all people with substance use disorders can face additional barriers accessing healthcare because going often means that they're in withdrawal, they feel judged in a healthcare encounter, a variety of things, and Indigenous people may face another layer of barriers in addition to that if they also use substances because of racism and discrimination that they may face in healthcare settings. So racist stereotyping, healthcare providers attributing their concern to alcohol use or substance use, even if it's not, and therefore downplaying or dismissing their concerns. And in that form, there would be discrimination and oppression in that context as well. All right, next slide. So there are a number of approaches that we can employ to provide culturally safe and humble care. So understanding the impacts of colonialism. So really viewing the patient like in that context to frame and conceptualize them as a person and taking a holistic view of the patient. Employing self-reflection, so reflecting on your own biases and systemic issues as well. Recognizing and addressing power imbalances, taking a holistic view of health and wellness and how someone's cultural beliefs and views and values factor into that, addressing and keeping in mind the social determinants of health, respecting Indigenous knowledge, traditions, beliefs, and practices is also important. Keeping in mind communication styles, your own, as well as the patient's, and how those may either facilitate or hinder the clinical encounter, and doing our best to meet patients where they're at. Understanding the community impact from the person sitting in front of you interacting with healthcare. So their condition, their presenting complaint may affect their community at large, and including their community or their sort of like chosen family, or whatever that means to them, as they see fit, and also be ways to provide culturally safe care, and approaching encounters with humility and openness. Whenever we want to talk about alcohol in clinical encounters, it's important to take a non-judgmental and trauma-informed approach, keeping in mind that this is a sensitive topic for everybody discussing their substance use. So I find it's often helpful to ground this sort of discussion by keeping in mind that substance use is initially adaptive. It does something for people who don't use substances because they're terrible. And what we're trying to do as providers is help people reach their substance use goal, live a life that has meaning for them. So really, they're the drivers of the ship. And understanding that substance use is not inherently good or bad. We want to know how it's affecting someone's function and help serve as a reflection point for patients to make an informed decision about how they want substances to fit into their life. So when we're approaching these discussions non-judgmentally, just keeping that in mind and having a very open conversation. In terms of having a trauma-informed discussion, there are many populations that are disproportionately affected by traumatic experiences: Indigenous people, women, LGBTQ populations, as well as people who use drugs face a lot of healthcare-related trauma as well. So keeping that in mind when we're taking a substance use history and approaching these clinical encounters. All right, next slide. So we first want to talk about, we want to open the conversation in an open way and very conversational, and really normalize why you're asking about substance use. So if it's the first time that I'm meeting somebody, like maybe it's a new patient intake or if I'm doing an addiction medicine consult, usually I'll start by talking about things that are less sensitive, talk about their past medical history, other things that they're more comfortable sharing. And then once that bit of rapport has been built, then delving into the substance use. And I often ask about substance use by, inquiring about, what substances are in your life these days, and try to keep it open-ended like that. And it can be helpful to include a comment, ask everyone these questions, just want to get a sense of sort of the substances that are in your life, or, what life kind of looks like for you. Again, we want to keep this as open-ended as possible. So as I mentioned, so I'll kind of ask what substances are in your life, but I think this orange bubble here about how alcohol fits into your life is a really key question, because especially when we are going down the road of looking at, does this person have an alcohol use disorder or substance use disorder, what we really want to know is how their substance use impacts their life and their function. So starting the conversation and framing it in that way can really help ground like what we're actually trying to get at. It's not that we want people to use or not use, it's just how is this fitting into your life overall. All right, next slide. So in terms of primary care, there are lots of great screening tools that can be used that are efficient and well suited for quick clinical encounters in primary care. So one is the SASQ, which basically asks about binge drinking. So in the last year, how often have you consumed more than 3 drinks for women or 4 for men on any one occasion? If you combine this with another screening tool like the Audit C, then that will increase your sensitivity of someone having an alcohol use disorder. And if they screen positive on these screeners, then we want to proceed with assessing for an alcohol use disorder by the DSM criteria. It's important to note that screening alone is not going to improve clinical outcomes. So you need to then follow up with that information and do something with it. Regardless of what they say their alcohol use is, if they're saying that they don't drink, then inquiring like what the reason for that is. Maybe they previously had an active alcohol use disorder and now are in sustained remission, and providing some relapse prevention counseling can be helpful. If they're within those lower drinking guidelines, providing encouragement, and if they're above it, then providing some education and going down a diagnostic route. Do they have AUD, and working on some strategies and figuring out their goals. So as we discussed, there are harms associated with alcohol use, including short-term exposures. Binge drinking is primarily associated with injuries, violence, and cardiovascular disease. Longer-term alcohol use is associated with things like cancer. Oh, sorry, next slide. Cardiovascular diseases and liver disease. So really, we want to emphasize that less is more in light of recent evidence and guidelines. All right, next slide. So when we talk about cancer and alcohol use, cancer is a leading cause of death in Canada, And alcohol is a known carcinogen. So it can lead to breast cancer, throat and mouth cancers, esophageal cancer. And a lot of people do not know the connection between alcohol and cancer. So this can be really important education to provide to patients. Next slide. So we want to discuss with patients the links between alcohol use and cancer, especially for people who are at higher risk. So often, people with family histories of cancer really want to do things to prevent developing cancer and may not be aware that their alcohol use is contributing. Alcohol is a group 1 carcinogen, so it's a known, we have enough evidence that alcohol does cause cancer. And again, this is often not known by patients. So providing that can really help people make a more informed decision about how they want alcohol in their life. All right, next slide. In terms of cardiovascular diseases, heart disease is the second leading cause of death in Canada, and alcohol is a risk factor for a number of cardiovascular diseases, so hypertension, heart failure, atrial fibrillation, and hemorrhagic stroke. There is a myth that alcohol in moderation reduces coronary artery disease, but that has been debunked. So sometimes that's something that can come up in clinical encounters, and providing that education to patients can be really important. All right, next slide. We could just, that's okay, I'll catch up. So in terms of liver disease, most people know that alcohol can impact liver disease, and there's sort of a spectrum of liver diseases from anywhere from fatty liver to hepatitis to cirrhosis. So providing education to patients that both long-term and short-term binge drinking can impact the trajectory of liver disease. Early diagnosis and intervention can help slow the progression or stop it. And there are a lot of complications when people have alcohol-associated liver diseases, risk of varices, hepatorenal syndrome, et cetera. All right, so last slide. So overall, any reduction in alcohol consumption will improve health outcomes and reduce the risk of alcohol-related harms. Higher drinking is associated with higher mortality, and increased incidence of motor vehicle accidents, medical comorbidities, and other complications. Conversations around alcohol use should be non-judgmental, trauma-informed, and culturally humble. And cultural safety is defined by the Indigenous person receiving care and should be actively practiced alongside cultural humility in all interactions. And there are several serious medical conditions that are attributable to long-term alcohol consumption, like cancer, cardiovascular diseases, liver diseases, and GI tract inflammation. We can move on to the resources that are there. Yeah, references. And we'll just draw your attention here to this BCCSU 24/7 addiction medicine clinician support line. That's available to all the providers there. If anyone has any clinical substance use questions, it's available 24/7. Thank you.